You're watching City Channel 4, your window to our community.
Welcome to Mercy. My name is Denise Connell. I'm the Director of Marketing for the hospital. And the first thing I want to share with you this morning is Mercy's mission, and that is to heal and comfort the sick and also to improve the health of the community. And putting on programs like this is one way we can do that. Specifically speaking of community health, every 3 years, Mercy does what is called a community health needs assessment. And that is where we survey the community and local health leaders and assess what the biggest health problems are in the community. The last time we did such an assessment was in 2012, and we learned that colorectal cancer was one of those problems that needed to be addressed. So that is part of the reason that we're here this morning. Before we start the program, I want to mention a few housekeeping items. Your parking this morning is free. I'm not sure yet if there is an attendant here or not this morning at the parking booth. If there is, just tell the attendant that you are here at the program this morning, and as I said, your parking will be free. We would like to invite you to ask questions this morning, and we find the best way to do that is if you write your question down on one of the pieces of paper that's on the table, or maybe another piece of paper you have, and pass them to the center aisle. I will pick the questions up at some point and read them out for everybody to hear them. Both of our doctors will be happy to answer questions. The last thing I want to mention is that at the end of the program, we will have door prize drawings, so hang on to that numbered ticket. We have 3 gift certificates to the Mercy Hospital gift shop, so be sure to hang around for that. Now I will introduce our 2 speakers this morning. Dr. Anjana Aggarwal is our first speaker. She is a Mercy gastroenterologist. She joined our staff in 2014, and she is in the practice Mercy Gastroenterology, which is on the first floor of this building. Dr. Aggarwal is board certified in internal medicine and in gastroenterology. Our second speaker will be Dr. Shireesh Saurabh. Dr. Saurabh is a general and bariatric surgeon. He also practices in this building in Mercy General Surgery, which is on the second floor of this building. He also joined our medical staff in 2014. Dr. Saurabh is also board certified in surgery. And I'll also mention as an aside that Dr. Saurabh came to help us begin our bariatric surgery program, which we launched earlier this year. And if you have any questions about bariatric surgery, feel free to check out our website after today's program or call Mercy for more information. That's a new program that we're very proud of. So first I would like to welcome Dr. Aggarwal to the podium. Thank you.
Good morning. Welcome. Thanks for joining us today. Thank you, Denise. I passionately talk about colon cancer screening because I think it's one of the cancers that needs more awareness. March is Colon Cancer Awareness Month, and in support of that, we wear our blue pins, so please do wear them today. So let's go ahead and get started. Colon cancer is currently the number 2 most common cancer in the United States. We actually call it the cancer killer number 2. So it's breast cancer used to be number 2, but we've done such a good job at screening for breast cancer, it's now number 3. Prostate cancer has gone down too. So colon cancer needs more awareness at this time, how to look for it, how to prevent it, and that's why we wanted to have this talk today. We have a 1 in 20 chance in our lifetime of developing colon cancer. That's a pretty good chance, you know. The interesting part about colon cancer is it's very preventable. And as we age, we see more incidence of colon cancer. It's most common after age 50. We're still seeing it at younger ages, but 50 is where we are starting right now to look for it. not only is it preventable, it's also curable when it's found in early stages. Our key is to prevent it, but in any case, many times we go in for a routine colonoscopy at age 50, and we will find colon cancer. 1 out of 6 patients who present for a colonoscopy will have colon cancer. So it is still curable if we can find it early. That's really important. One interesting fact I come across all the time is the wives will say, my husband doesn't want to have a colonoscopy. He thinks it's a female disease. That's why I came in for a colonoscopy, so I can encourage him to have his colonoscopy. So I wanted to bring this point out today. Men and women have equal lifetime risk of having colon cancer. It's not just a female disease, if that myth is out there. At least 75 to 90% of the colorectal cancers can be avoided by early detection and removal of what I call precancerous polyps, and I'll talk more about that. But keep that word in mind. I'll say that over and over, precancerous polyps. So polyps are abnormal growths that grow in the colon. You have a flyer from ACG in front of you, the yellow pamphlet. If you look in it, there's some color pictures about how polyps look like. If these polyps are removed, then we can prevent colon cancer. And that's the whole purpose of screening. Most of these polyps go unnoticed, so they're not going to have symptoms. They'll just keep growing in your colon. Hence, we have to go look for them. And that's what we call screening, is to look for these polyps before they have any symptoms and try to prevent the cancer. Even early colon cancers may produce no symptoms. So another misconception I see is, I don't have symptoms. Why do I need to go have my colonoscopy? Well, because early colon cancer will be asymptomatic most of the time. You're not necessarily going to know you have a cancer growing in there. We don't always feel it. We don't always see symptoms. So screening for colon cancer is important twofold, I think. One, to prevent the cancer by finding the precancerous polyps. And second, if the cancer is present, already started to grow, we find it at an early stage. Some possible symptoms that one may present with that you may want to ask your doctor to refer you to a gastroenterologist is new onset abdominal pain, blood in the stool, change in the size or consistency of the stool, change in your bowel pattern. If you're constipated, you suddenly get diarrhea. You usually have normal stools, you get diarrhea, or you get constipated. Any change that is out of place from your norm should, ask a question, do I need to have a colonoscopy if you haven't had one? At this time, colonoscopy is the preferred method for screening for colorectal cancer. The American College of Gastroenterology considers colonoscopy as the gold standard. Gold standard is what we would compare other tests with for colorectal cancer screening, because it allows us to directly look at the entire colon and identify these suspicious growths that we can then also remove at the same time. We can certainly remove most of the polyps. Not all cancers can be removed by me as gastroenterologist. That's when we need the surgeons, Dr. Saurabh types, to help us out. As of 2013 statistics, and we are waiting for the 2014 numbers, 136,000 new cases of colorectal cancer were seen each year in the United States. And despite this data that I just presented to you, that it's a preventable cancer, we need to do screening, 1 in 3 American adults aren't coming in to do their colonoscopies. So only 60 to 65% patients are coming in to have their colonoscopies. And our goal at this time is by 2018 to increase this compliance to 80%. So if you look at NCCRT, which is the National Colon Cancer Roundtable Conference, their motto is to get people to come in and have more screenings done. And so this is why we wanted to create the community awareness in our community by talking about it. We got 3 more years to increase it beyond 20%. 50,000 people are expected to die of colorectal cancer each year as of 2013. And screening could save at least half those lives. We have to ask a simple question to our doctor. Ask about a colonoscopy and how can we make those 25,000 lives live. There's a lot of lives we can save. So usually we would recommend for average risk patients. Average risk is somebody who doesn't have a strong family history of colon cancer or some other personal history of colon cancer, inflammatory bowel disease, etc., to start colonoscopies at age 50. The American College of Gastroenterology does recommend for African Americans to start colonoscopy at age 45. That guideline is a little different as compared to American Cancer Society. If you have just one first-degree relative with colon cancer or polyp, this is very important, or polyp, at age over 60, you're still considered average risk. So when we ask family members, we shouldn't just ask about colon cancer. We also want to ask our siblings, have you had polyps on your colonoscopy? Okay? And what type of polyp did you have? I think we don't do a good job telling the patients what type of polyp they have. Most patients will say, oh, my polyp was nothing, it was benign. Well, you need to go a step further. Benign just tells you the polyp is not cancer. But do you know if your polyp was precancerous or not? That's the golden word for me. If your polyp is precancerous and you have a sibling, then they are more at risk for growing those kind of polyps. Okay, and I will expound on that. If you have just one sibling or a family member who had this advanced type of polyp and they're over 60, you're still average risk. But if you have more than one family member who had colon polyps that are precancerous at any age, you're higher than average risk for colon cancer and polyps. Okay, I know this is a lot of information, but I think this is really the key to educating our patients and empowering them, because I ask this question all the time to my patients who come in for a colonoscopy. Do you know this? Do you know this? So I hope I can get the message out today. If your children, siblings, they have any family members who've had cancer or polyps, we find out what type of polyp, at what age was it first found, and how many members do we have with that history. So if you're a high-risk patient with a family history of colon cancer or advanced polyp at age less than 60, or more than one family member, we would suggest starting colonoscopy 10 years before the youngest diagnosed with colon cancer, or age 40. Okay, you don't wait till you're 50. So if you had a brother or a sister who had a polyp that was precancerous or colon cancer at age 45, you got to start at 35. If they were 58, you start at 40. Okay? So this is really important, is when to start early. Okay? And if you don't know, please give us a call. We'll walk you through it. This is what I do. I'm not going to get into more of the colon cancer syndromes. That's a separate topic. But there are certain families who are more at risk for colon cancer. They have HNPCC syndromes or FAP. They have to be screened even more closely than what I just said. If you have a clear colonoscopy at age 50 or your index, screening colonoscopy, and there's no family history that puts you at a higher risk, you can go 10 years between a colonoscopy. That's if you had no polyps and no family history. 90% of the 90% reduction in cancer risk is seen after colonoscopy and removal of polyps. That's a big chunk of cancer that we can prevent just by removing polyps. Now, this is the first part of the talk. I'll move on to the second part. A lot of patients don't like to prep for the test. And I don't think I can make it 100%, for anybody. But I think I'd like to give a few points how we can make the program successful because adequate prep is key to success of detection of polyps, which we call adenomas, and successful prevention of colon cancer. Okay, I think I missed that on the slide. I apologize. This is what an excellent bowel prep looks like. You can see the fine detail of the lining. We call it the vascular pattern. That's the blood vessels. This is how I can see flat polyps. Otherwise, I can't see them. If you have stool in front of these blood vessels, I can't see a polyp distorting these blood vessels. And this is what we need. Okay. An ideal prep would be where you get cleaned out well. It doesn't change how the lining looks. We don't have to give it over a prolonged period of time, causes no discomfort. Well, we haven't reached there yet, have we? It's safe, doesn't cause much problems with fluid and electrolyte balances. It's simple. Patients will accept it. And we can use it both for in and outpatient, settings. Currently, we are splitting our preps. We all remember the gallon. Most of you may be familiar. Patients come say, I don't want to drink that gallon. So we are going to about low volume preps, about 2 liters instead of the gallon, which is 4 liters. Okay? And we are splitting it into a morning, evening and morning dose or 2 doses so that we can have them drink it better so they're not as nauseated. They don't feel like they're going to throw up or as bloated. The other important reason that patients may not be aware is when we do the first part of the prep, between that and the procedure time, more stool comes into the right colon. The right colon is where the flat polyps are usually missed. So we want to give the second part of the prep hoping to clean that right side out. Okay? So that is why we are trying to tell you to wake up in the middle of the night and do that second part if you're having a morning test. It's not to torture you, then my drugs work better when you come in. Of course, you sleep better. But it is really important for us to be able to help you to find those polyps. This is a very busy slide, but what I wanted to show on this is I would think of preps in 3 types. One is the polyethylene glycol-based preps. One is the sulfate-based preps, which is the lower 2, and then the phosphate-based preps. The perception is, give me less to drink, and I'll do it. And if you may have heard, the Fleet's phosphosoda prep got taken off the market. It has a black box labeling now because it caused kidney problems. Those are the phosphate-based preps. It's not on this slide because we can't use it anymore. But the tablet preps that patients are familiar with, that we can just take tablets and drink water, those are also phosphate-based preps. So if you're younger, you don't have much kidney problems, you're not on antihypertensives like lisinopril, and you don't have constipation, you have regular bowel movements, that's the only scenario I tend to kind of go towards those tablet preps. But they have a chance that they may not clean you out very well. They work well in many patients, but if you're older, you have a slow bowel, they don't clean you out well. So it kind of defeats the purpose, of doing the exam. So I usually like these polyethylene glycol preps, and the 2-liter preps are the movie prep, the half lightly, and things like that. By using, again, low volume prep, we're hoping you can drink it better. If you feel like you're going to throw up, if you start drinking it a little slower than what we told you to, it might help. Just take it easy, take a deep breath. You can flavor it with Sprite, Crystal Light, ginger ale. Some people like lemon slices, If you want to bypass your taste buds in the tongue, you can use a straw. The only flip side is you may swallow more air and feel a little more bloated, but some patients like the straw. I have sometimes given nausea meds to patients to help keep the prep down if they know they threw it up the previous time. Sometimes it's preconceived notions, I am going to throw it up. I tell the patients, you may throw it up, don't worry, okay? Just try to think through it, take a deep breath, sit back, relax, and do your best, okay? If you can't do it, we'll talk again, we'll give you a nausea medicine, we'll help you get through it. But don't cancel your test and not do it again, talk to us. I can do a lot of things to help you to get through the test. It's not a pleasant experience, but think about it. We can prevent cancer. We're trying to prevent a number 2 cancer killer in the community in the United States. We've done so well for breast cancer. We can do really well to prevent colon cancer. It's a one-day discomfort. You'd rather not be in the hospital having surgery and sitting there for a week, with a stoma, or, you get hooked back, your bowels are not waking up. There is discomfort. There's no pain, no gain, right? But there's a lot of gain here, okay? And I've tasted the preps, if you wonder about that. They're not good. Hence, I've figured all these out. And if you've had a prep that didn't sit well with you, tell the doctor, we can change the preps. We have many options now. I've done this for about 15 years since I graduated and, did my fellowship. We have so much better stuff now that we can get you through than we had 15 years ago. So it's a communication, it's talking, it's understanding what you're worried about, and then we can adjust it accordingly. Again, I like the polyethylene glycol-based preps. I can add some other, like Miralax type polyethylene glycol products, some stimulant, bisacodyl or Dulcolex, to help empty the colon out. The reason I like these is they cause less fluid shifts. We call them isoosmotic. So they sit in the lumen of the colon and pull water into the colon. They don't cause too much sodium and potassium shifts. Some will happen, there's no doubt about it. But in patients who have kidney problems, who are on a lot of antihypertensives, for blood pressure, they're still safer than the phosphate and sulfate-based preps, I feel. And they don't damage the lining of the colon. So we can see better. We don't just see a lot of redness because of the prep. Which the phosphate preps used to do. The Fleet's phosphosoda used to do that. So this is some clear fluid in the colon. You can see, it kind of blurs the lining, but I can still suction this out, okay? I have a very narrow channel in the scope. I can suction this out through. So I can work with this. We see this quite commonly, after the prep. So don't worry about that. There's some air bubbles sometimes. We can wash these as well. But you see how it obscures? I can't see, right? So that's why the prep's so important. Now, see, this looks a little thicker, right? You can see this so well, but you can't. And look at the folds, how big and thick they are. So we're trying to look behind folds, and then you got this stool in front of it. It's really hard to look. So the prep becomes really important. If I can wash it, good. But if I can't wash, and it looks like this is hard to wash. Even though this says it can be washed off, some of this won't come off. So especially in patients who smoke or on iron, this is very sticky stool. Try washing this. Now imagine I have to look for a flat polyp in this prep. I can't. I'll miss things, right? And look at this. This is not even going to come through my scope channel. Okay? So this is a poor prep. And we have to stop and re-prep you, bring you back. If the preps fail, I give some extra instructions. Tell patients don't eat too much salad, raw vegetables or fruits in the week before. I see this very often. Patients think we're having a colonoscopy. Let's eat all the vegetables and fruits we can. It's going to clean us out. Actually, they sit in your colon longer, I find, and they plug up my scope. So if you actually eat softer foods, more cooked vegetables rather than raw vegetables, it's easier to clean you out, okay? Sometimes we'll tell you to do a 2-day liquid diet than 1 day. I know that's really hard. That's something I try to avoid. I might do more of the soft diet, the week before. And then I add additional stuff like Miralax a couple days before or Dulcolex a few days before. And then you drink the main 2-liter prep the day before the test. So we have to do that many times just to get you through the prep, so we get a good look. Patients who are on pain medications, tramadol, morphine, hydrocodone, these are called opioids. They're very hard to clean out. If you've had a poor prep before, you have to come in and talk to me or the doctor because we want to give you that extra prep to clean out. Don't just come in for a direct access colonoscopy because you have more chance of not being cleaned out. Like I showed you, it's going to look like this. Then you're going to have to clean out again. You're going to be unhappy. Chronic constipation, if you have less than 3 bowel movements a week, you push, you strain at stool, you don't feel like you empty out regularly, those patients need extra preparation. Men tend to not get cleaned out well sometimes, especially smokers. You have diabetes slows your bowels. Many times you need extra prep. So again, we try to put these in our, pre-procedure instructions. If you see any of those, and you feel like you may not get cleaned out, best to come and talk to us, and we'll tailor make the prep for you, okay? At least 20%, which is 1 in 5 colonoscopies, have a poor prep. And this, again, we can't see the procedures longer if there's a complication, which complications are low, but then you spill the stool out into the abdomen, can have more septic complications. We have to bring you back sooner. We can't give you longer intervals between the colonoscopy, so there's more cost, and the patients are not happy with the provider because they're like, we did everything right, why couldn't you see? So we want to improve your satisfaction with the provider. We want to improve the detection of polyps. So prep is really, really key to success of this colon cancer screening program. At least 5% of colon cancer patients have had a colonoscopy 3 to 6 months before their diagnosis. And the quality of exam is very important. So the prep I've already stressed, the withdrawal time, how much time we take to come out, during the colonoscopy. So we first go in all the way to the right, and then we look on the way out. And at this time, they say 6-minute withdrawal time in a nicely clean colon is adequate. It seems like a short time, but it's actually a long time when we are looking. So we need to take at least 6 minutes or more. Some patients are cleaned out so beautifully, we can get done in 5 minutes. So that's okay, but somewhere in that range. And how much experience does the person doing the test have in recognizing polyps, especially flat polyps, and taking them out entirely? Okay, so that's real key. So training and experience of your endoscopists are critical. Your pamphlet has information. I've kind of taken some of that here from the pamphlet. We as gastroenterologists receive special training in doing the colonoscopy by far than any other specialty. The other specialties that do it are surgeons, primary care providers, and they usually do a great job, but we just do a larger volume. I've done over 12,000 colonoscopies in the last 10 years. I do more than 1,200 procedures a year, both upper and lower. So you just this is what you do, right? If you asked me to do an appendectomy, I couldn't. That's what Dr. Saurabh does. So we emphasize attention to detail, and we can find polyps better. So make sure you ask the question, how many procedures your physician does, what's their track record of being able to find polyps. There's a quality measure called adenoma detection rate, and what's your complication rate, And because we do more procedures, we may have more complications, but our percentages are still lower. So we would tell the patients the risk of poking a hole in the bowel is less than 1 in 1,000, but we may be at less than 1 in 5 to 10,000 because we are doing so many. So we're still better at that, I think. And I'm not tooting my horn here. I just am stating the facts, I hope. So again, why take chances with colon cancer? Let's save some lives. Let's just ask the question to a provider, should I have a colonoscopy? Thank you.
Hi, good morning, everyone. So I'm Dr. Saurabh. I'm a general and bariatric surgeon, and I'm going to talk a little bit about the management of colorectal cancer. So once Dr. Aggarwal has diagnosed colon cancer or rectal cancer, then what do we do? So I'm going to talk about management, mostly surgical, because I'm a surgeon, so that's what I do. So we'll start with the surgical management of colon cancer. So this is this is a colon. So this is your cecum, this is your ascending colon, transverse colon, descending colon, sigmoid colon, and then this is the rectum, and then the stool comes out here. So when Dr. Aggarwal does colonoscopy, she examines the entire thing. So now if you look at the colon, this part of the colon that's known as sigmoid colon and the cecum and ascending colon are the most common part of the colon which have cancer. They account for total around 50%, and then the rest 50% is the other part of the colon and rectum. Now, like Dr. Aggarwal said, a colonoscopy is the single best diagnostic test, and this is how it looks. And she can see polyps, biopsy them, get better pictures, and actually let us know what exactly is going on as compared to any other test for screening of colorectal cancer. Now, if you can't do colonoscopy due to technical reason or the patient can't tolerate prep or any other reason like that, then the other option is a double contrast barium enema. In this, a contrast is injected from the bottom, and then multiple X-ray pictures are taken of the abdomen. It's not ideal, but it's the second option. So now, how do we work up a patient once they have been diagnosed with colorectal cancer? So a little bit about what I do when they come to my clinic first time after a diagnosis of colorectal cancer. So first thing, I would do a complete history and physical exam, know what their medical problems are, what previous surgeries they have had, what medications they're on, do a complete exam, and then try to assess what the extent of cancer is, like if it's spreading to different parts of the colon, or is it spreading to the lymph nodes, to the liver, different organs. So basically assess the local and distant extent of the disease. So I would get some labs on the patients, which would be basic hemoglobin labs, liver functions test, and then this CEA is a tumor marker. Its levels are elevated in patients who have colorectal cancer. Plus, it's also used to assess their prognosis, and when they come back after surgery, this is also used as a follow-up measure. Then a CAT scan is a very important test we do before surgery in most patients with colorectal cancer, because it helps us to know exactly where the cancer is, how big it is, if it's spreading around. So this is a very important test. We also do a chest X-ray on these patients to make sure they don't have any tumor in their lungs, because if they have one, then we might have to do more tests or the treatment management changes. And then again, a colonoscopy is the most important screening test, and not only to know where the tumor is, also to make sure there's no additional tumor there, and also it gives us a biopsy, so we know exactly if it's a polyp, it's a premalignant condition, or it's actually a colorectal cancer. So this is a basic workup we do. Now I'm going to show some pictures about how we look at the images on CAT scan and things like that. So this is a CAT scan picture, and for a patient who came to the ER with a right-sided abdominal pain, and so now this is how your abdomen looks when they take CAT scan pictures. Now this is your liver, and now this thing is the colon, and this is a little bit thick. And then this is another view, and you see this is, again, colon. This is kidneys. This is bones. And this is thickened. So once you see a lot of images, you kind of know what is normal, what is thick. So this is a patient who had a thickening in her colon, and she underwent colonoscopy, and it showed obviously a mass in there. So that's how colonoscopy is very important. Now this is another patient. He came in with left-sided abdominal pain, and on CAT scan he had a mass in his sigmoid colon down here. And then this is another image which shows that the cancer was spreading to the abdominal wall. So this is the abdominal wall, this is the colon, and then you see it's kind of spreading up here. The arrow points towards the tumor. And now it not only tells us if the tumor is spreading around the colon, it also gives us an idea if it has spread to liver or any other organs in the body. So now this is again a CAT scan, and this big thing is the liver. And now you see these black spots on the liver. That's the tumor spread to the liver. So that's why CAT scan is very important for our planning for surgery, to exactly know what we are dealing with, what the stage is, and how can we help the patient. Now, for rectal cancer, the workup is pretty much the same like with colon cancer. There's 2 additional tests we might have to do before we actually decide surgery or other treatment options. The one is how far is it from the anal verge. So rectum is around 4 centimeter proximal to the anal canal. And with what we do is that we could do a proctoscope, we can put this a small scope, we put it in the clinic, and kind of know exactly how far is it from the anal verge. Colonoscopy also tells us that. And then the other thing for rectal cancer is to know how far is the tumor spreading in the wall of the rectum, and if there are lymph nodes involved. And for that, there is a test known as endorectal ultrasound. That is, they put an ultrasound in your rectum and they take pictures around there. The other option would be to get an MRI of your rectum area. So basically, these tests helps us to determine the stage of rectal cancer, because that's how we determine what kind of treatment the patient is going to get. So now this is an MRI picture, and it's difficult to say, but this arrow kind of points towards the rectal cancer, and it shows that it's spreading through the wall of the rectum. And this is another MRI picture, and you see these dark spots. So that's are basically enlarged lymph nodes. So again, MRI also helps us in staging rectal cancer. Now, this is a endorectal ultrasound I talked about. So what we do is we put a probe down your rectum, and that probe takes ultrasound pictures of your rectal wall. And this is the tumor around here, this black spot, and you can see it spreading through different layers of the rectal wall. And again, I'll go over the staging part, and it'll show you how it helps us in knowing what stage the tumor is. So now, staging is a way of describing the cancer. It kind of tells us the depth of the tumor and where it has spread. And it basically uses T, N, and M. So T is basically tells us if the tumor has spread beyond the layers of the rectal wall. So now, this is a rectal cancer. So now, stage 1, it's T1 or T2, which means it's basically spreading through the mucosa layer. So like colon has different layers. There's a mucosa inside the pictures which Dr. Aggarwal just showed, the mucosa. And then there is a muscle layer, and then there is outer layer, and then you get outside the colon to the other organs. So this one is T1 and T2 usually sees it spreads through the mucosa layer of the colon. And then T2 is T3 and T4, it basically spreads through the muscle layer, and then T4 is basically it goes outside. So with all these tests, we kind of try to figure out what the stage of the tumor is. And then stage 1 and 2 cancers are the colon, which means that the colorectal cancer is localized within the bowel wall. It hasn't spread outside. Anytime you have a positive lymph nodes, the stage becomes stage 3. Anytime there's a lymph nodes enlarged. And stage 4 is if the tumor has spread beyond the colon, like that is to liver. So that's how when you see a doctor and they might say, oh, you are stage 1, stage 2, stage 3. So it's important to know what stage is, because the treatment, it varies from one stage to another. And all these tests which I showed you kind of helps us in knowing what exactly the stage is. Because stage helps us in knowing what the treatment would be and what the prognosis is also going to be of the patient. So that's why all these tests a patient goes through before surgery are very important. So now, before we do surgery, what we do is, obviously, we also do a bowel prep like Dr. Aggarwal, and which could be a Go Lightly prep or a Maxitrate. It's not as extensive as she says, so I'm okay if there's some fluid in there or there's a little bit of stool in there, which is fine. But we also do bowel prep, and especially for left side cancers. Then if a patient is going to get a stoma, which I'm going to talk later on, we have our nurses go through the patient about what about the stoma teaching and what the exact location should be, which is comfortable for the patient. Then before surgery, I also give the patient blood thinners because there's always a risk of blood clots. And then we give some antibiotics in the operating room. So now, surgery for colon cancer. So that colon and rectal cancers are, the treatment is a little bit different than, like both of them are not the same treatment. So like based on the stage, like so if you remember stage 1 and 2, the cancer is just localized in the colon. It hasn't spread out. So lymph nodes are negative. It's all within your colon. So in these cases, just surgery is good enough. So we do surgery, resect your colon, put you back together, and that's it. You just need regular follow-ups after that. Now, if the cancer has spread to the lymph nodes, colon cancer, in that case, we still have to do the surgery, but after that, you would need a chemotherapy. So if the lymph nodes are positive, then you would need chemotherapy. And now if it's stage 4, that is a person has a colon cancer and it has spread to the liver, lungs, different part. In that case, chemotherapy is the treatment. And surgery would only happen if the tumor is causing some obstruction or it's perforated or it's really affecting your quality of life. But it's going to be more of a palliative surgery rather than a curative surgery for stage 4. Now, for rectal cancer, the treatment is a little bit different. So now, stage 1, like we talked about earlier, that we want to know how far is the tumor in the rectum from the anal canal, because that makes us decide what kind of surgery we can do. So if the cancer is in the upper 1/3 of the rectum, stage 1, we basically do a surgery that is remove that part of the rectum and put you back together. If it's in the middle and lower 1/3 of the rectum, sometimes we can just resect that part through the anal canal, so we don't have to give you a scar on your abdomen, and it's a less invasive surgery. But then it should be small. It should be like 8 to 10 centimeters from your anal canal, so we can get through there. So that's for stage 1. Now, rectal cancers, if you have stage 2 or stage 3, that is, stage 2 is like the tumor has spread beyond the mucosa of the colon or rectum to the muscle layer. Or stage 3 is if the lymph nodes are involved. In these cases, we give the patient chemoradiation therapy before actually going through surgery. That's why the ultrasound I was talking about, the MRI, helps us in knowing if the tumor has spread, the rectal cancer has spread anywhere. Because giving a neoadjuvant chemo and radiation therapy is the first line of treatment. And after you're done with this therapy, which could take around 5 to 6 weeks, then we plan for surgery, and then you would also need a chemotherapy later on. Now, stage 4 is that the cancer has spread to different parts, and chemoradiation therapy is the treatment of choice in this case. Now, if the tumor has spread to liver and it's just one lesion, this one part, in that case, if there are a suitable candidate for surgery, we can resect that part of the liver, and it kind of cures you from the cancer. So even if it's stage 4 in a rectal cancer, if it's just one part or maybe a couple of parts which are resectable, you can still have a cure from the cancer, for rectal cancer. If not, then chemoradiation therapy is the treatment of choice. Now, this is an interesting picture. So this patient had a rectal cancer. I'm sorry if you guys don't like the pictures, but I think it's easier to explain rather than me telling you that, oh, this is how I do surgery and stuff. So this patient, this is the rectum. This is how it was looking on colonoscopy. And this is a rectal mass. And this is how it looks after a chemoradiation therapy. Almost gone, right? So with the chemoradiation therapy for rectal cancer before surgery, it kind of downstages the tumor, decreases the tumor burden. And some patients who were not a surgical candidate before, they can become a surgical candidate after chemoradiation therapy. And it also decreases the local recurrence of this tumor, and the survival also improves. So that's why a chemoradiation therapy pre-op for stage 2, stage 3 rectal cancer is very important. So now for colon cancer, coming back, when we have done all the workup, we have done everything, and now we know that we have to do surgery. So how do we do the surgery? So obviously, if the surgery can be done either open-wise or laparoscopic. So if anyone has had a gallbladder surgery, laparoscopic surgery would include the same tiny incisions, which are 1 to 0.5 centimeter in size, and it could be four incisions. And we resect the part of your colon out, bring the bowels together. This is how the bowels are brought together with a stapler. And if needed, then you get an optional ostomy. So now, this is again the colon. Now, if the cancer is in the cecum, we basically remove the right side of your colon out, so this part. And then we hook this part of the colon to your small intestine. If the cancer is in your transverse colon, this part of colon, we remove this part of the colon out and hook these two together. If it's on the left side, again, this part. It's again this part, we remove the entire left colon. And if it's in the sigmoid colon, we basically remove sigmoid, a little bit of descending colon as well. So basically, when we remove the colon, we not only remove the part which involves the cancer, we also try to get some 5 centimeter of normal colon on both sides. And we basically take the lymph nodes out. So that's why, because lymph node staging is very important to know if a person is going to need chemotherapy or not. So it's very important to do proper staging. So when we resect it, we resect the colon, plus we take the lymph nodes out and the vessels. And lymph nodes are usually along the blood vessels supplying that colon. So that's why you see this, we're trying to take all this blood vessels out as well with this. Now, laparoscopic colon resection. So most of the time we try to do surgeries laparoscopically, and because the advantages are a lot. So now this is, these are tiny incisions for laparoscopic surgery, and this is for a sigmoid colon cancer. And so we put 4 or 3 small incisions. These are 5 millimeter or 1 centimeter size incisions. And then we take the colon out through this small incision up here. And the advantages are a lot, and I'll tell you a little bit more. So this one is for right colon cancer. So we put our 2 instruments up here, we put our camera through here, and once the surgery is done, we make an incision a little bit bigger and take the colon out through this incision. So now advantages of laparoscopic surgery is that you have less pain after surgery, your bowel function returns faster, you start moving around faster, the hospital stays smaller, and most people get back to work faster as well. And now since the incisions are so small, the risk of wound infection is also low. And the cure rate is pretty much the same for both open and laparoscopic surgery. So it's not like doing it laparoscopically is not doing the right surgery or not taking enough colon. So a lot of people we do laparoscopically if they are a good candidate for it. Now this is the open surgery. So you can see if how an open incision would look. It's a big incision, so going through the entire abdomen, so a lot of pain. A patient suffers from, and there's also risk of wound infection. Now this is an ostomy, which I'll talk a little bit later. So the incision could be anywhere in the midline. It could be of any size, but obviously the pain is more. But if someone has a very large tumor or has had multiple surgeries in the past, in that case they might not be a laparoscopic candidate, and we do an open surgery. And this is how, when we remove the colon out, we send it to the pathologist so that they can look at it under microscope and tell us the exact stage of the tumor. So now this is the tumor, how it looks from inside once we get the colon. So this is a colon, this is a small polyp, and this is the cancer under the polyp up here. So this is how it looks, the colon, once it comes out. Now rectum is, so now this is the anal canal, this is where the stool comes out, and now this is the rectum. So it's around, I would say 12 to 15 centimeter in size, and it's divided into 3 parts. Lower 1/3, middle 1/3, and upper 1/3. And depending on where the cancer is, the surgical management differs from that. So if it's in the lower one part and it's stage 1, or it's in middle one part and stage 1, you can probably remove it through this direction rather than making an incision on your abdomen. So that's a less invasive surgery. And again, rectal cancer surgeries, again, we can do it laparoscopically or open, depending if a patient is a good candidate or not. If it's in the upper and the middle part of the rectum, we could basically resect that part of the rectum and hook the remaining rectum to the colon. That's known as a low anterior resection, because by this surgery, it allows us to preserve the anal sphincter. Now, if the cancer is in the lower 1/3 of the rectum, so we need to remove at least a few centimeters of normal tissue to make sure the margins are negative. But if it's in lower 1/3, we are basically taking part of your anal canal. So it's the anal sphincters are gone. So it's difficult to achieve a good preservation or good continence if we hook you up if it's in the lower 1/3. So that's why in lower 1/3 cancers, we do an abdominal perineal resection. That is, we remove the entire rectum and anal canal, and you'll get a permanent ostomy for your life. So that's for lower 1/3 of cancers. And now this is again a rectum, just to tell you about what kind of surgery we do. So this is the anal canal, and this is a big rectum. And when we remove the rectum, we also try to remove all the lymph nodes and the blood vessels around it, because that's very important for knowing the staging of the tumor. Also, it lets us know about if there's lymph nodes involved, and also improves the prognosis of the patient. Doing a total mesorectal excision, that is removing all the mesentery and lymphatics around there, the prognosis gets better for these patients. So that's what we try to do. It's not very easy, but that's the best surgery for these patients. Now, I have been talking about hooking the colon back together, and you guys must be thinking, how do you put the two ends together? So this is just a simple step. So this is the colon. This thing is the anvil. So we have a circular stapler we use to hook the two bowels together, right? So this is the anvil which goes in the colon, and we kind of stitch it around there, okay? Now, and then the circular stapler comes out through the rectum. So this is a person's rectum. This is the uterus. And through the bottom, we put the stapler in, and this part comes out, this sharp part. And this part goes into this part. See that? That has a hole in there. So this part goes into here, and this is how it looks. You see that? So this is the rectum, this is the colon, and these two things are coming together. So we have a screw, we kind of start rotating, and it starts bringing the colon and the rectum together, and kind of joins together, and then we fire the stapler, and it creates anastomosis. And so this is the anvil which goes here. This is the thing which comes out from the bottom in the rectum, and then they come in together and forms the anastomosis. So that's how the anastomosis is done when we talk about hooking the bowels together. Okay, and now a little bit about ostomy, since you guys might have heard about ostomy. So ostomy, what we do is bring a healthy piece of bowel, or healthy part of the bowel, out through the skin. So so this is the part of the colon, and this part of the colon is brought out on the skin. So now when you have a bowel movement, it's going to come out through this opening. And these are the ostomy supplies and bags which are put around there so that they can nicely and safely hold up all the stool and everything in here. So this is how the ostomy looks. Now, there are two types of ostomy. It could be a temporary ostomy or a permanent ostomy. So temporary ostomy is done if you're having a very low anastomosis and down in the pelvis, and your surgeon thinks that there was some problems during the surgery, and he was not sure if the anastomosis looked good or there was some problems. In that case, he would just give you a temporary ostomy for a few months, and then once everything settles down, then he'll hook you back together. And or if this person has multiple medical problems, is a high risk, then we would just give the person a temporary ostomy just for a few months. Now, and the permanent ostomy is done for the cancers which are in the lower part of the rectum, where it's difficult to put them back together. In that case, the person will have a ostomy for all their life. And it's, like I said, the height of the tumor from the anal canal. So it's very low rectal cancer, and we give them a permanent ostomy. So this is a little bit about the surgical part of the surgery, and I hope you guys know about the ostomy now. So after we are done with the surgery, depending if they had an open surgery or a laparoscopic surgery, their stay in the hospital could be anywhere between, on an average, I would say 5 days or 7 days. And then most people get back home, and it might take a few weeks before they're completely pain-free. And regular follow-up is very important after that. So they would probably need a repeat colonoscopy in 6 months to 1 year after surgery, and then a frequent follow-up for the first few years, and then annual follow-up. So in the first year, it might be every 3 months or 6 months, and then slowly it's once a year. And during those time, you'll be getting a regular physical exam, blood work exam. We can check for your tumor markers to make sure everything is good. So that's about the surgical management. Thank you. So yeah, we can take questions now.
Is there an age that after that age you didn't need a colonoscopy? So we have to qualify the answer as to the age of the patient and their previous history. So if you're between ages 75 and 85, you've had a baseline colonoscopy, you've never had polyps or colon cancer yourself, and no strong family history of colon cancer and polyps, you can elect to stop having a colonoscopy. But if you're a young 75-year-old whose health is like a 55 young patient, and I should say 75 young on that, then as you live longer, you can grow polyps too. So it's your choice, okay? I would recommend to the patient, I said, if you're 75 young, you're going to live the next 10 years, you might as well do one more. And if you don't have any health problems, if you have major health issues, then the benefit of doing a screening colonoscopy or surveillance colonoscopy may not be that much. Your risk may be more for the test. So I individualize every patient. I don't just say stop between 75 and 85. And if you've had polyps and you've had cancer, then it's a totally different discussion. I have been taking 2 teaspoons of Miralax in orange juice for a number of years. Is this too much every day? May I allow I don't know the patient, so not knowing more than what I have in the question, the usual dose of Miralax is a capful, which is 17 grams in an 8-ounce glass of water twice a day. So not orange juice, in water. Look at the cap you have, fill it to the line on the cap, that's 17 grams twice a day. Thank you. Does diet have anything to do with getting colon cancer? Yes, it does. For now, they say diets based on vegetables, fruits, less red meats are healthier diets, and so they're better for preventing any cancer, no matter what, but specifically colon cancer. Also, weight has something to do with it. So obesity is linked to multiple cancers, as in colon cancer as well. So if you eat healthier, you maintain a healthy weight, that's good to prevent colon cancer. I can't change your genes, right? And how long we live, but that's what diet we can change. Thank you. Is that uncle?
My mother.
Mother.
Mother, I think so.
I'm not sure if this says mother or uncle. My mother is something died of colon cancer. My children, 60 and 62, are they at high risk? I'm not sure. Maybe we can ask we can clarify.
My mother-in-law.
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 My
okay.
mother-in-law.
Sorry.
Mhm.
Okay.
Sorry. My mother-in-law died of colon cancer. My children, 60, 62, are they at high risk? So that's for the children.
Yes.
It's a grandparent, correct? So if it's just that one grandparent, the children are not more at risk, but they're over the age that they should have started colonoscopies already. So they should have started at 50 for sure. Thank you, Denise. Thanks. This is for me. It says for Dr. Aggarwal. You said to speak with siblings as first-degree relative to determine if we are average or high risk. Is a discussion with the children or parents also helpful to determine high risk? That's question one. Yes. So parents, usually if they've had colon cancer or polyps, 60 or less, would be a risk for the patient. And if you as a patient have had colon cancer or polyps, then I would also advise, besides siblings, for children to start early. They are also first-degree relatives. Number 2 question, what steps can we take to reduce chance of getting PCP or colon cancer? Precancerous polyps or colon cancer, that is diet, lifestyle, etc. So I think we kind of answered that question. Healthy eating habits, healthy weight, exercise, not smoking, and then, talking to your family members, knowing what your genetic risk is, and getting your screening colonoscopy at the appropriate age. That's for you. Thank you. How awake will I be during colonoscopy? So typically, we would use what we call conscious sedation, which is a light sleep medicine. We use 2 drugs, Versed, which is like a benzodiazepine, your Xanax type meds, and fentanyl, which is a pain medicine. Every patient is a little different. Most patients will sleep through the test, or they'll forget what happened during the test. They may complain of discomfort, but they don't remember that. And I would say 95 to 98% patients are like that. However, if you take pain meds, you're already on anti-anxiety medication, some types of antidepressants, you may have tolerance to the drugs we use. You may remain more awake, or the drugs don't work for you. If you have high anxiety, you drink a lot of alcohol, the drugs don't work well. Sometimes you're awake and you can watch. I've had patients say, I don't want to have sedation, can I just watch? And they do fine. So, every patient's different, but most of the time sedation works well, and that's how we would like to do your test. Anesthesia can be used, but we have to arrange it separately. It's a deeper level of sleep. There's more cost with it because the anesthesiologists are another specialist who have to come in for the test. So we try not to do every test with anesthesia. And you don't need that level of deep sleep, for every colonoscopy. So it's more risk in that sense to get anesthesia. I think the anesthesiologist may feel differently. Thank you.
What is being done to...
Oh, there's one more. I'm sorry.
Yeah.
There's one more question on this. If I absolutely refuse a colonoscopy, what should I do instead? That's a kind of a long discussion, but I'll make it a short answer. There's a stool for occult blood testing, double contrast barium enema, CT colography, stool for DNA. They all have their own guidelines. I think maybe the person who has this question will have to talk face-to-face in clinic and go over all those. Okay, but there's guidelines for it. I think in the handout you have from American College of Gastroenterology, it touches on those other tests as well a little bit. What is being done to lower age insurance pays for colonoscopy? Dr. Odoresh at University to get cancer organization to lower age. I don't know the answer to this. I already think that there's a lot being done in Washington to try and get covered at age 50. When I started doing this, even the initial screening colonoscopy was not covered by insurances. So there's a lot of red tape on this. The more awareness we make, the more campaigns we do as patients, just like we do for breast cancer, I think our voices will be heard. Okay, but it's not a great answer at this time that insurances will cover it. They'll cover it at a lower age. And when you take out a polyp, they're going to say, I did a surgery where I'm not a surgeon, and they'll make you pay for, some insurances do that. They won't cover it as a screening colonoscopy. So I have my opinion on it. I might get in trouble for saying it loud. So I'm sorry, I don't have a good answer for that one. 2014 Harvard School of Medicine newsletter suggests not having a colonoscopy after age 75, I think, too dangerous. Have you heard of this, and what is your opinion? I think we answered that question. We have to individualize when to stop colonoscopies, talk to the patient, what's the patient's preference, what's their history, have they had their baseline colonoscopy. There are papers that say it's too dangerous. Well, we have to qualify what dangerous means, who we are doing it. If you're 75 young, you have no medical problems, you don't take any pills, and you're healthy as a horse, well, I would do a colonoscopy. That's my personal opinion. Because that person's going to live to 85, and you are going to grow polyps, and those polyps will grow into cancer. So the person who wrote that article has to qualify what dangerous means. I think they're referring to perforations. Again, if you go to a qualified person who's doing a lot of these, the risk is smaller. It's not a zero risk by any means. But, you have to, again, go through the rigmarole and see what's best for you as a patient.
Yeah, I think I'll just add to that I've seen patients who are like 90 years old, 92 years old, and we see a lot of patients, and they're pretty healthy, and then they say that, they haven't had colonoscopy for 10 years, 15 years, and then at 92 they find that they have a colon cancer. But they're pretty healthy otherwise. So then I have to do a surgery on them, which could have been avoided if they were still doing colonoscopies, and it was a small polyp maybe 10 years back. So I think that's a good point now that we have an aging population and people are pretty healthy as well. So maybe to increase the age for colonoscopy.
Anymore?
It's a whole colonoscopy.
Sorry.
No, it's fine, actually. It's fine.
Ask about chance of polyps cancer higher up in digestive tract. Usually, since the talk is about colon cancer, it's one of the more preventable cancers. The upper GI tract is different. There's not many cancers there that we screen for. Again, I didn't talk about the inherited colon cancer syndromes. The FAP types have more risk of upper GI tract cancer. So we don't screen unless you have that genetic inherited syndrome in the upper GI tract. Hazard from diverticuli, very common diverticulosis. There are pockets in your colon. Everybody seems to have them. Small number of patients, 2% or less, might get an infection, which is called diverticulitis. We don't walk around with diverticulitis. We walk around with diverticulosis, which are the pockets. We can't predict who's going to get an infection. If you do get an infection, you'll need antibiotics. If you keep getting recurrent attacks of diverticulitis, you see a surgeon and get that part of the colon taken out. Otherwise, we'd recommend eating soluble fiber supplements, to help the colon empty those pockets out of stool with less pressure. Complications with intestinal disease such as Crohn's, there's a bunch of them. That's like a whole other discussion. Maybe the person who has the question, we can talk separately. Flex-6 still done, not very many, not for screening colonoscopies. I may have certain patients, I may have to look at a certain site or just get a biopsy, but it's not for colon cancer screening that we are doing as many now. What do we do to make the prep pleasant? I think we talked about that. Nothing's going to make it perfect. I showed some ideas, how to try and make it better. Can a flat polyp be removed during colonoscopy, or would it always require surgery? It would not always require surgery. We do try to take them out as much as possible. Some years back, I ran into resistance when I raised a question about changing to a different gastroenterologist within same practice advice. Depends on the practice. I can't comment on which practice you're in. We also discourage that. If you're dissatisfied with one, we work as a group, so you may want to just approach a different practice, or talk to your gastroenterologist, see what your concerns are, what you're dissatisfied with. If they can help you, do something better, communicate with them. How new is the split dosing protocol? I would say at least 2007 on, if in my best recollection. Implications for type of prep if patient would be constipated, if she were not taking daily Metamucil. I think we talked about that. We need extra prep in patients who are constipated to clean them out. Soft diet, additional stimulant, bisacodyl or Miralax, few days to week before the prep. Yes, thank you.
So is renal cancer the same as colon cancer? No, it's completely different. For renal cancer, we usually send these patients to the urologist because they might need a partial or complete nephrectomy and other treatment. And colorectal cancer is a little bit different because those are diagnosed by a colonoscopy, CAT scan, and then we have treatment guidelines for that. And then the second one is a small cell neuroendocrine cancer start in colon, spread to a liver stage 4, 34-year-old male. Would they have been symptoms, presentation? I think so. They neuroendocrine tumors, they usually have symptoms depending on what kind of neuroendocrine tumors are. They produce, it could be an insulinoma, in which case they'll have an increased amount of insulin secretion. So they might have symptoms of hypoglycemia, blood sugars are low. It could be a glucagonoma, in which the glucagon levels are high, in which case they might have skin rash, or their diabetes is over the top. So they'll have a lot of hormone secretion, and then they might have symptoms related to that. And they might have skin rash, things like that. And usually neuroendocrine tumors, they have a good response, even if it's stage 4 with surgery and debulking. Even if it's spread to liver, they have pretty good response to these treatments.
And they live very long.
And they live. So it's not like a colorectal cancer that is, if it has spread to liver, the prognosis is very poor. These patients, they undergo surgery. They go debulking surgery. That is, you try to remove as much as tumor as possible, and their prognosis is better than other cancers. Okay. All right.
Thank you.
Yep. Any questions, sir? Okay. Thank you, everyone. Thanks for coming.
Thanks, Shireesh.
I want to thank Dr. Aggarwal and Dr. Saurabh again for such a very informative program. That was just great. Thank you so much.
You're watching City Channel 4. On TV, online, on demand, on Facebook, and now on the go on your mobile device.